Welcome everyone to today's webinar on mitigating poor bereavement outcomes and supporting staff during COVID-19. This is another webinar that is co-sponsored by the Chaplaincy Innovation Lab and our very good friends at Transforming Chaplaincy. So we're always happy to be together for all of these topics. I'm just going to introduce a couple of very technical things, and then I will get out of the way and hand it over to George Fichette, who will talk about our interviewer and our presenter. I'll just remind everyone that since you registered for this, you will automatically get a link to the recording in the next couple of days. So if you need to leave or you miss a point that you're interested in, don't worry, you can always go back and watch it later. If you have any sort of technical difficulties during the webinar, feel free to send me a message in the chat. I can't guarantee that I can actually fix it because there is so much that depends on what's happening at your end. But if you have difficulties, please do let me know, and I will see what I can do to get it figured out. So welcome once again. Thank you for joining us. I'll get out of the way now and hand it over to George.
Michael, thanks a lot. Always good to work with you on the webinars that we co-sponsor with the Innovation Lab. Friends, I'm really excited about today's webinar. Let me introduce the kind of key people here. First, let me introduce you to Reverend Shelley Varner Perez. Shelly is a chaplain researcher and senior program manager for spiritual care research at IU Health in Indianapolis. Shelly's also on the faculty of the Daniel F. Evans Center for Spirituality and Religious Values in Healthcare at IU Health. Shelly is a former Transforming Chaplaincy Research Fellow. Oh, we love the research fellows. And she's a co-leader of the Transforming Chaplaincy APC Webinar Journal Club, whose next session, by the way, will be September 15th. And if you need more information about the Webinar Journal Club, go to the APC website. We're especially delighted to have joining us Dr. Lucy Selman. Lucy is a senior research fellow in palliative and end-of-life care research group in population health sciences at Bristol Medical School at the University of Bristol in Bristol, UK. Dr. Selman's clinical research interests are primarily related to palliative and supportive and end-of-life care. Prior to joining the University of Bristol, she worked for 11 years at the Cecily Saunders Institute at King's College London, where she completed her PhD in palliative care. Lucy, when we think about PhD in palliative care from the Cecily Saunders Institute, it's like you actually got trained at the Vatican. You know, it's like the most holy place it could have been, is it, right? Lucy is widely published in this field with a specific focus on psychosocial and spiritual aspects of the illness experience and of care provision, decision-making and communication, family caregiving, cultural factors in care provision, and end-of-life care education and training. I first became aware of Lucy's work about 10 years ago when I saw her report on an 8-item measure of spiritual well-being for use in palliative research in Africa. And it was just really wonderful work and very exciting to read. And I followed and appreciated Lucy's research on measures of spirituality in palliative care. And Lucy, multiple times I've actually cited the research you did on the survey of palliative care practitioners' priorities for research about spirituality and palliative care. I think that's just really very informative and very helpful to see that. When I saw the report about your recent Journal of Pain and Symptom Management paper on bereavement support on the front lines of COVID-19 recommendations for hospital clinicians, I just immediately said, oh my gosh, we have to see if Lucy will do a webinar for us about that. So I called up Shelly and I said, let's talk to Lucy and see if she'll do this. By the way, this paper was among the top 5 Journal of Pain and Symptom Management papers cited in social media in August 2020. So Lucy's not only just a rigorous researcher, she's actually a palliative care research rock star, right? And so really delighted to have you with us for this conversation, Lucy. Thanks for joining us. Shelly, Lucy, I'm going to turn it over to you.
Thank you, George, for that introduction. And Lucy, it's wonderful to have you with us today. I was very excited when George introduced me to your work and specifically this article, and very timely information for us to consider. So I really appreciate you joining us today at the evening time in the UK for this conversation. So the structure today will be that I will spend about half an hour interviewing Lucy and asking her some questions about her article. And then there will be an opportunity for us to take your questions that you can type in the questions box, so that you can have access to the article that we're going to be basing our conversation on today. The slide that you should be able to see has a QR code for you to be able to pull up that article on your own computer or device. So in Lucy's recent publication in the Journal of Pain and Symptom Management, she highlights several risk factors which can lead to prolonged grief disorder, post-traumatic stress, and other poor bereavement outcomes among relatives. And she also describes frontline staff, the potential for moral injury and distress. So there's this sort of dual approach looking at both relatives' distress and staff distress. So today we want to talk a little bit about those risk factors for poor bereavement outcomes. And particularly, I want to focus our time on her evidence-based recommendations made in the article, because I think all of us are still learning about COVID and very interested in how we can help with the bereavement process to mitigate those poor outcomes. So it's not that difficult to situate chaplaincy and spiritual care in the context of this topic. Certainly chaplains are providing spiritual care to patients and families at end of life, which is completely central to the recommendations in this article. Chaplains are also assisting in formal and informal ways in advanced care planning, communication with families, and navigating telecommunication during COVID-19. I know for myself and the chaplains at my facility, these are skills that we have learned and improved rapidly since March. In the introduction to her article, Dr. Selman identified the number of COVID-related deaths globally as over 190,000. This morning, when I checked on the Johns Hopkins COVID dashboard, the number of global deaths is 4 times that number at 860,000 deaths. We are learning, and yet there is so much unknown. And we appreciate this opportunity to speak with you today, Lucy, about evidence-based recommendations and resources. Do you have any comments you'd like to add here about your research focus and relevance for a spiritual care audience?
Well, first of all, just thank you so much for inviting me. I really appreciate the opportunity to speak with you all today. And thank you, George, for the very warm, probably slightly too glowing introduction. I'm very flattered. So I guess, I see bereavement and bereavement support very much as part of my interest in psychosocial and spiritual and cultural aspects of end of life and palliative care. And I think, unfortunately, bereavement care is sometimes seen as a bit of an add-on within the context of end of life care. And I think that's sometimes also, unfortunately, true of spiritual care. So I guess I see myself as sort of wanting to fight the corner for those aspects of healthcare which are so important, but which are often not given the attention they deserve. Would it be helpful to tell you a bit about how this paper came about?
That would be fantastic.
Yeah, so in March here in the UK, we entered lockdown around the middle of March. And it became clear quite quickly, I think, that we were facing a situation where our hospitals could potentially be overwhelmed. And bereavement care was high on the agenda for a lot of clinicians working in inpatient settings. So I received a number of emails from clinicians in my local area who knew I had an interest in bereavement, saying, what can we do? Are there any practical tips? What does the evidence say? What can we do? Like, we want to revisit our bereavement leaflets. We want to provide resources for family members, but we didn't really know where to start. So I initially just came up with a list of bullet points. So I did some searching through the literature, and I thought, actually, there are some key things that we know we can do. And there's also key things where we can say bereaved relatives are going to be finding these aspects particularly difficult. For example, obviously, social distancing, the infection control requirements. So the paper really started as me trying to respond to a clinical need locally. And I wrote a piece for The Conversation, which is an online kind of news blog site And that was picked up by a lot of different people as well. And I got clinicians contacting me because they'd read the piece that I'd written on The Conversation, which was about kind of grieving during the pandemic. So with my colleagues that I used to work with at King's, we decided actually let's write a piece on the evidence around bereavement support, because although this is a new pandemic, bereavement is not new, and there's been research going on in hospital settings and looking at how we can best support family members for many years. So we thought we could look at the different bodies of research and try and learn and adapt what we know from the evidence to give some kind of concrete evidence-based recommendations for those working on the front line. So that's really how this paper came about.
That's very helpful. And certainly we've all been reaching for practical tips during COVID, and especially in supporting relatives with bereavement during this time. So these recommendations are very helpful. Can you say a little bit more about how you came to be concerned about religion and spirituality as part of your research?
Yeah, of course. So as George mentioned, I now work at the University of Bristol, which is in the west of England. I've been here for about 4 years, but before moving here, I lived in London and I worked at the Cissy Saunders Institute, which is part of King's College London. And while I was there, I started there as a very junior researcher in 2005. And I was working with Professor Harding. He was Dr. Harding then. And he had an interest in global health and global palliative care. And I was working with him on a project in Africa, working with hospice services in Uganda and South Africa. And in the course of doing that work, the importance of spirituality within the experience of patients, within the experience of patients' lives, and how embedded they were in the community became really clear. So the kind of religious resources that they drew on in managing their illness and in finding the strength to kind of deal with their illness was very clear to me. And I thought, okay, this is an area I would like to look at more. And so I decided to do my PhD on spiritual well-being in South Africa and Uganda. My PhD, which George mentioned, it was a mixed method study. So I looked at sort of levels of spiritual well-being. And then I analyzed some qualitative kind of in-depth data as well, which was to understand in more detail sort of how spiritual well-being kind of played out in patients' lives. And what I found is of people receiving palliative care across a number of hospices in South Africa and in Uganda, about a quarter were experiencing spiritual distress. Which is obviously like a very significant proportion if you think about it. So this is people who are saying, that they haven't found peace, that they have, existential worries, that they may have religious concerns which are not met. And then in addition to that, I thought it was really interesting. So I used a quality of life measure, and I discovered that actually spiritual well-being was something valued by patients more highly than physical activity or their own personal comfort. So they rated their spiritual well-being as of kind of central importance to their quality of life. And I thought that was really interesting. And the qualitative data then allowed me to explore in more detail kind of how people described and talked about their spiritual well-being and just the kind of nuances within the idea of spiritual well-being, that it encompasses so many different things for different people. And in the African context that I examined, it was very much a relational concept. So related to their family relationships, their place in the community, their role in being able to contribute to their family, contribute to their community. So that was my PhD really, in a nutshell. And another aspect actually that I should also mention is that I was very interested in how religion could be supportive, and certainly I found that it did enable people to have that kind of inner strength, but it also flagged the kind of more negative aspects as well of the church, and for example of some faith leaders saying you don't need to take your antiretroviral medication, we will pray for you. Those kind of complications that the healthcare staff also had to deal with kind of on a regular basis. And also sort of, the more sort of forceful aspects of the church where, you know, pastors may come to the hospice and try to convert people to their religion, or ask, you know, try and persuade them to change their beliefs in quite a forceful way. So it wasn't all roses, you know, it was definitely trying to understand the pros and the cons, and the complexity of the role that religion and spiritual belief can play within the illness experience. So that's kind of how I got interested in spiritual care. And as I mentioned to George before we started as well, you know, I was really honoured that we had Reverend Dr. Peter Speck at the City Saunders Institute, who was one of the main kind of forefathers of spiritual care research in the UK, and he sort of took me under his wing and gave me a lot of mentorship and support through my PhD as well. And since then, my research interests have shifted somewhat, partly due to issues like funding. You know, it's not always, you know, as a lot of you will be aware, it's not always that easy to get funding for spiritual care research. But I've always kept my interest. I've done work on related areas, so communication, advanced care planning, particularly interested in treatment decision making in the context of renal disease at the moment, and how the way that staff members talk about different treatment options kind of influences that treatment decision making. So yeah, so it's one of my many interests, but it's something that I do feel passionately about.
Sounds like there's a breadth of work that we could learn from and would be very interested in reading. And also hearing you speak about the role of spirituality and quality of life and how patients rated that makes me think that we should have you tweet that out for us, so that that's understood more broadly in healthcare. Sometimes chaplains don't feel that spiritual care is valued as much as we'd like to see. And so certainly research that brings spiritual care to the fore is really important and meaningful. And so we thank you for those contributions.
Yeah, it'd be my pleasure. I'll do that afterwards.
So you've mentioned, I want to shift slightly into the nuts and bolts of the article for today. You've mentioned risk factors for poor bereavement outcomes for relatives, which include, let's see, dying in an intensive care unit, severe breathlessness, patient isolation or restricted access, significant patient and family emotional distress, and disruption to relatives' social support networks during COVID-19. Will you say a bit more about how these risk factors play out, and whether the risk factors are similar for relatives and frontline staff, whether that the impact on the patient sort of impacts relatives and frontline staff similarly?
So the risk factors for poor bereavement outcomes that I highlight in the article are in relation to family members, or friends and family members. So the people that bereavement researchers have researched in terms of trying to understand the impact of certain conditions around end of life care and death, you know, subsequently, you know, after the death. A lot of the time, research, you know, it's quite a kind of broad topic, poor bereavement outcomes. So within that, there's a lot of different things indicated. So I thought it was important to kind of try and group them together. So the studies that I reference in the article relate to things like complicated grief, now also called prolonged grief disorder, post-traumatic stress disorder or symptoms related to post-traumatic stress, anxiety, depression, those kind of poor mental health outcomes. And then in addition, there's research that's been done looking at sort of satisfaction with end-of-life care among bereaved family members. So we also drew on some of that research in terms of trying to highlight what's useful and what is not so useful for bereaved family members.
And can you say a bit more about prolonged grief disorder?
So prolonged grief disorder, I'll read the definition. So it involves intense symptoms of grief that endure for more than 6 months after loss, separation, distress, intrusive thoughts, and feelings of emptiness or meaninglessness. So there's a sense with prolonged grief disorder that people may feel stuck in their grief, like they're unable to, you know, find any kind of happiness, they're unable to find any sources of meaning, you know, that they may kind of just start feeling very bereft and I guess bereft is the right word, you know, they are, you know. It's tricky because bereavement itself is, you know, it's a natural part of life. It's something that all of us will face at some time. So it's important that we don't kind of pathologize that. But equally, I think the work that's been done around prolonged grief disorder is really helpful, because it does flag that there's about 10% of bereaved individuals who do require specialist support to help them in going through what can be an extremely distressing, heartbreaking time.
And certainly the relatives we support, we hope that they do not find themselves in a situation with prolonged grief disorder and or sort of other mental health impacts if possible. So can we talk a little bit about some of those recommendations to mitigate those bereavement outcomes, especially before a patient's death? I'm going to shift our slides so that folks can see the table 1 from your paper that has some very helpful recommendations. And if you could just talk to us about a couple of those.
Sure, yeah. So there are a number of things that we can do before a patient's death. I flag in the article the role of advanced care planning. I don't want to talk too much about that in detail, because it may not be something that chaplains see so much as their role, but I think that is really important. And we know that where planning has happened and family members feel like they've been included in their planning, that helps them in their bereavement. A major kind of, I guess, cluster of things in what you can do before a patient's death relate to communication. So first of all, I wanted to draw attention to the recommendation around family members having their names and contact details of you know, someone they can contact that knows the patient, that kind of has their case in mind, that can kind of advocate for them and find out information that they may want. I don't know if that's on the next slide, actually.
Let me see.
Or maybe it was on the previous one. I have it here as well, but oh, sorry, it was on the last slide. So where possible, assign a specific contact person for each patient to help ensure continuity of care. Now, continuity of care is something which always comes up in research with bereaved relatives, that it can be so difficult when you're, especially in the COVID-19 context, if people aren't able to be there and they're kind of phoning and they're unable to get through to somebody who knows their loved one and knows kind of what they need to know, then that can be really, you can imagine how difficult that can be. So if there can be 1 or 2 specific assigned contact people, that can be really helpful. And their role, that person, is also to kind of signpost to information and help liaise with other members of the care team kind of for them. So to play that kind of advocate role. So I think that's something where chaplains could be really, you know, really helpful, play an amazing role in kind of facilitating that relationship.
And in the article, I think you specified that maybe outreach from the team twice a day could be particularly helpful. Can you say something about that particular recommendation for that frequency?
Sure. So that actually came out of some early research, also published in the Journal of Pain and Symptom Management, from a Swiss team. It was, her name is Tanja Fusi-Schmidhauser, I think. And they published a really interesting article basically on their clinical experience, you know, because they've been there. This paper was written quite early on, but obviously they've had the kind of the peak of the pandemic. They've gone through this really intense time clinically already, and so they published that quite early, which was very helpful. So it's based on their clinical experience, and they said, you know, twice a day could be really helpful. So that's something that we drew on in making that recommendation.
That's helpful. Thank you. And also, one of the recommendations here is around improved communication with PPE. Can you say a little bit more about that? I think it's really been difficult for chaplains to and other team members to find ways to connect with so much PPE on. Certainly, we're used to having it in situations where a patient is in isolation, but the amount of PPE might be especially large at this time.
Yeah, I think PPE has been a huge challenge here as well, in the UK and in Europe. I mean, I guess we all know that a hospital admission is alien and confusing and frightening for so many people. And the addition of PPE is just kind of, you know, it's just going to make it worse for so many people. You can imagine how frightened patients might be, unable to communicate or unable to see the people around them. So I think PPE is a really important one, and it's an area where there have been quite a few sets of recommendations and helpful papers that have come out since this paper. And there are some really great resources on the Centre to Advance Palliative Care in the US has a kind of COVID-19 response resources section, and they have some great resources there. But just to kind of flag a few bullet points around communicating via PPE. So you can nowadays, in the UK anyway, and it's probably the same in the US, you can actually get transparent masks, which obviously if you do have to wear a mask, that can make it easier because people can see and read your lips, which is particularly important if people are hearing impaired. And also it just enables the clinicians to kind of express their emotions a bit more clearly rather than just trying to use their eyes to express emotion, which is quite difficult. So it depends where you are. It might be that people are just wearing a visor, or that, you know, or they could have a mask on, a transparent mask, I think can be really helpful. Another thing which people have done here is printing out photos of themselves and sticking it on their visor or on their uniform or their clothes, so that there's a photo of them with their name and the patient or family member kind of knows who they are. And then in terms of communication itself, I think it's even more important to kind of attend to your gestures and your body language, and kind of projecting warmth into your voice. You know, when you're probably having to kind of overemphasize everything you say as well to kind of try and break down that barrier and make it more easier for people to hear. So I think speaking really clearly, but also trying to bring in that emotion is important, especially, you know, in the work that you guys do as chaplains. It's even more important. At the beginning of an encounter, it might be helpful to do a kind of audio check, you know, make sure that they can actually hear you. And also, I think, to acknowledge that the PPE is there, you know, like just to say something like, I know I might appear a bit intimidating, dressed in all this, but, you know, I really do want to understand what's been going on with you, and just kind of acknowledge that it's there and it's not normal. But it's something that you can, you know, just express still that you're keen on kind of trying to build that connection. You're going to need to leave extra time. I'm sure you guys have all been finding this anyway, but I think it's even more important to spend time on the small talk before you move on to the big talk, and just to kind of try and establish that rapport early on. And because it's really difficult for somebody to see your emotions when you are in PPE, it's more difficult. You know, you're using your eyes and things, but it's more difficult. I think naming your emotions might also be helpful, just to say, you know, I can imagine this is a scary time for you, or, you know, I'm feeling X yourself, and just to kind of bring yourself into the room probably be really helpful to try and humanize the encounter somewhat, I think. And I think, I mean, this might sound a little bit strange, but I think practicing is probably really important. To just, you know, if you feel like, oh, I'm in all this PPE gear and, you know, how do I kind of negotiate this? And, you know, if it makes you feel awkward, then just maybe just sit down with a colleague and just kind of give it a try, and try a few different techniques for communicating and see what seems to work well. So I hope that's helpful. But I would also say, you know, go and have a look at the resources out there on the web as well, if it's an area that you feel you could do with a bit more advice in or support with.
And I believe on your recommendation table, which is table 2 in the paper, there was a resource for communication cards actually that can be used. So
yeah,
folks,
yeah. Oh, sorry, I forgot to mention those.
Can have a look at those as well.
Yeah, so those are card medic cards, which were developed by some clinicians in the UK based on the experiences of actually a patient who had survived an ICU admission with COVID-19. And they're basically, it's a free resource. You can go to the Cardmedic website, and they're digital communication tools, which you can look at on a tablet or on your phone, and the patient can read it. And so you can, so it's sort of like, you know, it can be really helpful if someone is hearing impaired, or if the barrier, the PPE barrier is really tricky. There's certain topics you can look up, you know, certain topics of conversation that you might want to raise. There's 10 different languages, and there's also a kind of read aloud function. So if someone's unable to see, then, you know, then you can use that function. So yeah, you know, check it out and see. It might be helpful.
And I've added those to the chat box so that folks can check those out. Let's talk a little bit about mitigating poor bereavement outcomes after death, the second portion of Table 1, because there are also some very helpful suggestions there, especially I know a lot of chaplains assist with bereavement programs in their hospices or hospitals or in healthcare systems. And so I think it's helpful to talk a little bit here. Would you highlight a couple of those recommendations that you'd like to point out for us?
Yeah, sure. So I think chaplains can play a really useful role in the signposting. So there's 3 different ways that I've kind of flagged signposting there. So one of them is around flagging bereavement services. So create a COVID-19 bereavement leaflet which signposts relatives to local bereavement support, which might be available. And this includes obviously web forums, web chats, you know, there's mobile apps you can use now as well. There's lots of different types of support that people can access. And I think that's really important because everyone's different and they like to access support in different ways. Then the second kind of area for signposting is local support services for bereaved people or those who are socially isolating. I don't know what it's like in the US, but in the UK, there's a lot of community groups that have kind of sprung up to care for people in the neighborhood who might be shielding at home and require kind of social support. So if you can see that someone in the family has health conditions or has other problems where they're not getting out and about and you kind of worry for them, then I think just to have access to those kind of local support services could be really helpful. And then the third area was around sort of information and guidance on registering the death and arranging a funeral or other type of service, including any support that might be available for funeral costs. I think that's, yeah, that kind of practical information is kind of really important. I would say that I think it's really important that all of those resources, leaflets and things are kept up to date, because I think that's one problem, is that things change quickly and services go out of, you know, they stop work, they stop functioning, they stop providing their services. And you know, I've actually had the experience myself. I was bereaved in a hospital setting and I was provided with a bereavement leaflet kind of sent home. And then 2 weeks later, I tried to call the number on the bereavement leaflet and the phone line was dead. And that's not what you want. Like, no. You know, that just makes you feel even more like, oh, there's nothing for me, you know. So yeah, so I hope those that's some helpful, some helpful advice on what could help.
And there's actually a question that came in through the chat that's relevant to that piece about bereavement sort of resources. Ian says that they've been doing a pilot program of specific bereavement calls to families bereaved because of COVID. And they're wondering if you have a recommended time period post-mortem to make those calls, days or weeks later, or a particular suggestion about the timing.
I think that's really tricky, and it's something that we looked into around the condolence letter. So, you know, we had a recommendation to send a personalized condolence letter because there has been some research in that area, but it's really not clear from the evidence of when you should send a condolence letter, like when's the best time. And maybe the answer is more that there isn't necessarily a best time and that it will depend on the individual. So for some families, within a few days would probably be really helpful. Whereas maybe for other people, you know, they might feel like, well, I really actually needed that after the funeral. So I think it's really important to do it, but I don't have a clear answer on kind of when is the best time. And it would be really interesting for Ian to share, you know, once they've been doing that for a while, to share what they think, you know, the best timing might be.
Yeah, it sounds like there's an opportunity for additional studies or data to sort of inform that process. I also ask about the personalized condolence letter. Can you say more about what that means? Does it mean that like if the letter's typed and it just like has the person's name at the top and you actually refer to a person by name, or are you talking about like a handwritten condolence letter? Do you have that much detail from your
research? So that particular recommendation came out of a very specific piece of research, which I have not made a note of. But it's referenced in the article, so you can look up the specific study which looked at the condolence letters. And what they found is the personalized condolence letter, which is personalizing in terms of their name, but potentially also the person who died and kind of mentioning their name as well. They found that it can help to kind of humanize the medical institution. It can make people feel like, okay, you know, when my loved one died and I left the hospital staff actually still are engaged and they still do care. But what they also found that a condolence letter without any further information about where to get support can actually cause more problem, like can do more harm than good. So if you send a condolence letter, it's also a great opportunity to enclose like a list of local support services or places they can go, people they can talk to. And again, so I would encourage people to look up that reference. So reference 32 in the paper on the condolence letter, if you're interested in that.
Thank you for pointing us to that reference. I appreciate it.
Yeah, so it's a study by Kentish Barnes. Again, I'm happy to tweet that reference afterwards if that's helpful. It was a study looking at condolence letters after loss of a loved one in an ICU.
Helpful, thank you. I'll try and get that in the chat box towards the end of our time. I also wanted to talk a little bit about the impact on frontline staff, because we've talked some about evidence-based recommendations for supporting bereavement and relatives. And your paper also references the potential for moral injury and distress among staff. And there's a really powerful statement. You write, self-care strategies and individual resilience tools such as mindfulness and reflective practice are insufficient. Resilience should not become another responsibility of staff working in traumatic conditions, but requires an organizational and systemic response. I'm hoping you might elaborate on that a little bit for us.
Yeah, I feel quite strongly about this because I think, you know, there has been a real emphasis on self-care and, you know, it being staff members' responsibility to kind of boost their own resilience and do yoga and adopt mindfulness. And I know those types of interventions and activities can help. You know, I'm very much, you know, interested in yoga and meditation myself. But we have to remember that staff support is actually an organizational and a cultural thing, and it's not the responsibility of the individual, you know, extremely busy doctor, for example, to somehow squeeze into their lives some additional, you know, self-care time. You know, what's required of them at work and how their working life is structured is actually an organizational responsibility. And the support needs to be available for them within the organization in which they work. And they need to feel, I think, you know, especially going through such a tough time dealing with COVID-19, staff need to feel like the organization they work for has their back and cares about their mental well-being, cares about their physical well-being. You know, we'll be able to provide enough PPE, we'll, you know, actually be able to provide them some support resources to deal with this, you know, what can be extremely traumatic aspects of work. And then writing this section, I did want to flag, because I think it's a great resource. So the book, A Field Manual for Palliative Care and Humanitarian Crises. So that came out by with Oxford University Press last autumn. And I imagine that they didn't realize, you know, that actually we were entering what is very much, you know, perhaps not what we may traditionally think of as a humanitarian crisis, but actually a lot of what they say in that book is relevant to, you know, the being in the midst of you know, such a severe pandemic as COVID-19. And they've actually made it open access, so you can read the book chapters online for free, which is brilliant. And there were 2 chapters that I drew on in particular. So one was a trauma-informed response to working in humanitarian crises, which focuses on the providers. And then there's also a very interesting chapter on spiritual care and kind of cultural and ethical aspects of care, which I also found interesting. So I would recommend that.
And was that listed in one of the references, or that's in the recommendations table? Folks are asking me to put it in the chat.
It's in the references. So it's referenced in 39.
Okay, I'll put that in the chat.
39. That's one of the chapters. And then there's another, the other chapter is also referenced somewhere. I can't see that right now.
And we're getting questions in. I think we're ready for some participant questions. So I'm gonna pitch one of these to you, and then I will chat box for folks. Marvin writes, I like Lucy's comment about not pathologizing grief. What do you feel about this in connection with modern popular world culture? Do we pathologize death, and should we?
Oh, that's a big question.
It is a big one.
Yeah, Marvin, I think it's, I think as working in the end-of-life care research field, I think that public engagement around death and dying and bereavement is really important, and trying to kind of shift our cultural attitudes to be more open to talking about death and dying, and to feel more confident in responding to bereavement and responding to serious illness is a key thing that we should all be trying to do as people interested in this area of work. The point around pathologizing bereavement, it's a tricky one, because we shouldn't pathologize something which is a natural part of life. But I think because it is a natural part of life, some people, perhaps if they haven't experienced a close bereavement, they don't quite realize that it can be intensely distressing. It can be totally transformative of your life. And it's a huge thing to go through. So, it even has positive aspects, I would say. Once you've been through grief, you can kind of look back on it and think, I'm here because of that difficult experience I had. But that doesn't mean that when you're in it, it's any less difficult and potentially traumatic. And I would say that, we know that there's this 10% of people who require specialist support, mental health services to kind of process their grief. And then there's a huge number of people who actually get by with support of family and friends. But at the same time, family and friends don't necessarily always know the best things to say and the best way to support people as well. So I think you need to kind of, I think there's 2 things. There's normalizing bereavement, normalizing grief and death and dying, and kind of encouraging people to be more vocal and open about those things. But at the same time, there's work that's needed to actually provide people with the skills and the knowledge and the awareness to be able to support their loved ones when they're going through serious illness or when they're going through bereavement. So I think it's both.
Wonderful, thank you. One of the people wrote that one of the questions we got was about whether there's a difference between a condolence letter and a bereavement card. They said their institution sends a bereavement card that all chaplains sign, but it's not in a letter format, and if there's a specific format that's come up in the research that you've read or done.
So in the Kentish Barnes papers on condolence letter, they actually, you can actually see as an appendix what their condolence letter looked like, I believe. They have 2 papers on that study that I've referenced in there. But I would see a bereavement card is very similar to a condolence letter. I suppose it depends also on how much, whether the bereavement card is personalized. I would see that as more important as whether it's in a card format or a letter. Does it make you feel like the hospital staff actually are talking about your loved one, and that they knew your loved one, and that they knew you, or they know your name, and they know you know, something about the person you've lost. I think that's probably more important.
Yes, that makes sense. Can the next person ask, can you restate what you said about self-care and the organization's responsibility in providing opportunity for self-care? Just say a bit more about the organization's responsibility or the organization's role.
Sure. Yeah. So I think with something like COVID-19, the first thing that we need to make sure is that healthcare leaders and organizations take responsibility and ensure staff are prepared for the emotional consequences of the work that they're about to do. You know, working in a pandemic is no easy thing. And, you know, moral distress where you're perhaps unable to do what you would like to do, or you end up needing to act in a way that contradicts your own kind of moral belief system, or that you feel something's questionable in how you've behaved, you know, that can have really serious consequences in terms of burnout, in terms of like how people feel about themselves and feel in their work. So it makes sense to try and kind of be upfront about some of the pressures and try and encourage your organization to have a culture of openness around the difficulties of working in this environment. We don't want staff members feeling like, oh, no one else is saying anything, everyone must be coping well, I'm the only one who's finding this difficult, you know. So I think that openness is really important. And then the other thing to think about is kind of providing staff members with resources and guidance and training so that they can, you know, so that there are resources there to help safeguard their mental and physical health. And I don't think that should be, as I mentioned, like a responsibility of the individual clinician to go kind of searching for that. I think it should be something that is made, you know, people are aware of and is kind of advertised and offered proactively.
I think I was just going to say that this is one of the things that has come up in conversations with frontline staff, with chaplains who have been providing care at bedside throughout COVID is, you know, there are some folks who are chaplains who feel like they signed up for this. You know, they care for patients with other infectious diseases. You know, I'm in this, I signed up for this. I've seen other chaplains who say, I signed up to do spiritual care at a bedside. I didn't sign up to be a chaplain during a pandemic. And so I think that some of the distress, as you were mentioning, has come about whether sort of people expected this and then how they're sort of integrating the new aspects of their role or what feel like new demands of their role into the care, which can really have a big impact. And organizational support is very important to help work through that.
Yeah, and also I think chaplains, they often play that role of supporting other team members. So that's another, you know, when the rest of your team is kind of really struggling and you're kind of the one who's being looked to be strong and kind of provide that that space and that you know, those resources for others when you're potentially feeling quite depleted yourself, you know, I can imagine that's really challenging. I think that, you know, the kinds of support that I think organizations need to think about are monitoring frontline staff, you know, being aware of who might be struggling, not in order to kind of castigate them, but in order to kind of support them and make them know that they're there and that they are going to be supported through it. Facilitating team cohesion, because we know that teams that kind of feel united are much more resilient. And then implementing certain strategies, for example, informal debriefing and kind of peer support, you know, that's really important. And I saw, as I spent a year at UCSF, and I saw like the senior chaplains there, how they would support the medical students rotating through the palliative care team. And I think that kind of peer support and informal debriefing is really important. And I did flag in the article that we do know, though, that kind of single session psychological debriefing can actually do more harm than good. So, you know, just offering everyone like, oh, come and see a psychologist for an hour and that's it, you know, that's not going to be helpful. It needs to be something that's more kind of built into how the service is operating, I think.
So sort of a one-off debriefing may not be the most helpful, but a larger structure or process for building team support through the organizational lens.
Yeah, and also access to kind of more ongoing formal support for staff who are struggling, whether it's, you know, bereavement support or other kinds of counselling that can support staff in their role. I think that, you know, there's definitely an important role for that as well.
Yeah, I know at my facility we have access to employee assistance program, EAP, and other resources, and those are helpful ones to remind staff about and utilize ourselves. I think we should be thinking about doing that when we need those resources.
Yeah, especially in COVID-19, where there's not only everything that's going on in work, there's also everything that's happening at home, and the fact that it's affecting our families. You know, we may live with people who are clinically vulnerable. We might be very worried about, you know, transmitting the infection to other people around us. So, you know, it isn't just it's not just work, is it? It's like I think for a lot of people, our work and our professional life has kind of merged into the personal life. You know, here I am at home, like talking, you know, working from home all the time. And I think the kind of impact of that shouldn't be underestimated, and organizations need to take that into account.
Yes, so the impact both at work, having a more stressful work environment, and then the stressors at home as well. Yes. I'm seeing a couple additional questions. There's a question here: how does a chaplain straddle the line of providing debriefing and emotional support to staff while also advocating for better and more humane working conditions for frontline workers? Do you have suggestions?
It's challenging. I mean, hats off to you guys who are working, you know, in the current environment. I think it's incredibly tough. I think in general, to have a kind of senior champion is always helpful when you're trying to bring about kind of organizational changes. You know, easier said than done, and I understand, you know, that's not always possible, but you kind of need to get some senior people behind you, don't you? You kind of need to get the buy-in from the powers that be, which is not always easy. But I hope that I hope that many of you do feel that you're getting support from the organizations you work in.
Yes, and I see a couple of just comments, not necessarily questions. Someone posted that in the UK, a question actually, in the UK, do funeral homes have chaplains on staff?
I don't believe so, no. I think that in the UK, funeral directors play an important role in bereavement support. So a lot of them, you know, see the bereavement support very much as part of what they do. So yeah, I mean, I'm not an expert on the kind of funeral industry in the UK, but I don't believe that they do. They have celebrants and chaplains that they work with in terms of, you know, delivering services. You know, but usually I don't think they have anyone kind of on staff.
And one additional question from the article, you mentioned relatives feeling guilt over possibly transmitting the disease, and that being part of a grief process potentially, which is a unique aspect of COVID bereavement, really, I would identify. Can you say just a little bit more about this and how it might be approached?
Well, I'm not a chaplain and I'm not a psychologist either, so I wouldn't want to give you like practice recommendations for how to deal with that. But the kind of, you know, I think you're right that there are certain things about COVID-19 that may bring up unique challenges and questions in the bereavement kind of process. And I think that, you know, often in bereavement we see guilt in some form, whether it's guilt of being the survivor, you know, in an accident, or guilt because a parent thinks if only I'd done X, maybe my child would have survived. So I think guilt is part of grief and bereavement, and it certainly plays a role in sort of more complicated cases of bereavement. So I think in COVID-19, yeah, I mean, you can imagine how you would feel if you did, you know, if you felt, for example, if your a daughter or a son, and you fear that you gave COVID-19 to your parents or your grandparents, and then they died, that could be, you know, that could be very difficult, challenging thing to work your way through. So yeah, so I think, I mean, there certainly are aspects around related to COVID-19 that make it particularly challenging. Especially, you know, we kind of touched on this, but not being able to see people in their last days, or feeling like you haven't said goodbye. We know from other research that sense of not having said a proper goodbye before someone dies is associated with more difficulty kind of further down the line. And it also relates to funerals, because in a sense you have these different moments of saying goodbye. There's saying goodbye in the lead up to a death, you know, in the days and weeks before a death, and then there's being present for the death itself, which is another form of saying goodbye. And then there's the funeral, which is, you know, your opportunity to celebrate and mourn and bring the community together to kind of, you know, collectively commemorate the loss of life. And COVID-19, it disrupts all of those three different levels of saying goodbye. You know, they're unable to see in the run-up, they're unable to be there and care as they would in other situations. They're often unable to be there for the moment of death. Yeah, and then again with the funeral kind of afterwards. And one of the things that was happening, like in the UK at the time when I wrote this and when we wrote this, was the inconsistencies across the country. So I think there was a sense of, you know, in some hospitals you could get access and you could visit your loved one. In other hospitals, you couldn't. So there was a sense of kind of unfairness as well, which I think is maybe inevitable when it was such a new situation. But I hope that going forward there'll be more consistent guidelines for services and for funeral directors about what's permitted and, you know, how people should actually support people in this going through such a terrible time, you know, to be bereaved during the pandemic.
Yes. Well, we really appreciate having you with us today. This has been such an important and robust conversation, and your paper and research will continue to be resources for us. Thank you for joining us, Lucy, and thank you for the research that you're doing. The slide that I have up now has additional publications by Dr. Selman, as well as a QR code to her page at the UK Bristol University, so you can learn more about her additional work. Do you have some wrapping up for us, Michael?
Yes, I just want to remind everyone that you will get a recording for this video in the next couple of days. I've seen in the question box a couple of requests for the slides. That'll be included with that recording as well, so you'll have all of this to check out as well. And then I would encourage you, look through the rest of our webinar schedule at chaplaincyinnovation.org. We have a number of events coming up. I know that we're going to have another event together later in October. And many more after that. So thank you, Shelly, for interviewing today, Dr. Selman for being with us, and thank all of you for joining us for this webinar. We will see you next time. Bye-bye.